are you guys willing to give me your best shot? It's not so bad. There's no grade on this. Yeah. Yes, just in case, I'm going to give you 5 minutes per usual. All right. Whenever you're ready.
Problem is she's having an acute ischemic stroke that she needs to be treated for. She's eligible for IV alteplase at a dose of 0.9 milligrams per kilogram and a max of 90, administered over 60 minutes with an initial 10% bolus over 1 minute. So that total dose comes out to 67.5 milligrams. So 6.75 milligrams over 1 minute, and then the rest of the remaining 60 minutes. And she can have aspirin for 25 milligrams by mouth after 24 hours after she gets the alteplase. We need to monitor her blood pressure really closely because it needs to stay less than 180 over 105 for 24 hours after she has the alteplase. So we need to monitor it every 15 minutes for 2 hours, and then every 30 minutes for 6 hours, and then every hour for 16 hours. Her next problem is that she needs secondary prevention of her stroke. So she was already taking lisinopril. That's appropriate. We need to know what her blood pressure is normally. We need to maintain that. The guidelines say under 140 over 90, but our hypertension guidelines we know are more strict at less than 130 over 80. I would like to get an A1C for her because we don't know anything about her metabolic status. Her glucose is okay, like in the hospital, but we don't really know what's going on normally. We need to change her pravastatin to atorvastatin 40 milligrams by ounce once a day for a high intensity statin. And then recommend therapeutic lifestyle changes for her. Another problem I have is that her total daily acetaminophen dose is really high, depending on how she's taking her as needed. So she's got acetaminophen at 1,000 milligrams every 6 hours as needed, and then she also has the 325 Marketo 2 tablets every 6 hours as needed. So we figure out like how often is she taking those. Probably need to discontinue the Marketo until she takes her acetaminophen around the clock if it's for her osteoarthritis, and see if that helps. And then no indication for the alprazolam. Who knows? It's not that great. She's 67. Perfect. That's all I got.
Awesome. Alrighty. Very good. That was in 2.5 minutes, so short and sweet. I like it. So let's see. For the group, I guess, if you don't mind, I'll give you feedback. So to me, 30 seconds-ish in terms of like giving some background is nice. You can do a little bit shorter if you want. I think it's helpful for you guys to have a second to like actually be able to tell yourself who the patient is. Otherwise, you're kind of all over the place. So I don't mind that. Again, I don't give points for it, but I think it helps people that usually have the best kind of like 15-second opener. Often, I feel like there's a correlation between the 15-second opener and like the rest of the problems. So I think it is a little bit worth your time in that moment. So one of the things that's interesting is when you kind of get on a roll like that and you're very methodological, if you're like, this is the problem, this is what I would do, this is why, this is what I'm monitoring. So I have actually nothing on here about blood pressure. So that's some time spent. It's a reasonable thing to talk about. You don't have any other issues, but you did hit everything else, which is really nice. So that's okay. So if you're very thoughtful about how you go through this thing, you actually can have time to hit problems. Somebody like, I just didn't know what to say. I'm like, it's okay, just say like the 5 things you need to say for each thing, and you'll probably will find more things than we intended for you to find, but that's okay, So, and like a couple of times we've actually had where like everyone, like we came back and I was like, okay, so it's like 6 of my students identified this as a problem, like what do we need to do? And the next year we like deleted it as a problem because it was like obviously a distractor. That's okay, so just keep moving. Alright, so with this in particular, I agree that the primary problem is that she's having an ischemic stroke. What would your guys' explanation of this be? Why do you think this is the case?
Symptoms or CT?
Yes. So we have signs of CT, and what is she negative for in particular? A hemorrhagic stroke. So that's very important for TPA. So very good. So we have ischemic stroke. So we got priority problem. on point. We got the ischemic stroke, we got a point. We said why, it was a point. Then, one of the things you gotta be very careful with here, which I think is a little bit, anyway, tell me why, I agree that she needs TPA and you have the correct dosing. Why can you give her TPA?
She's within the 3 hour window.
Yes. And she's lacking what? Like, what are you,
Like she doesn't have a diagnosis like diabetes, and there's
Yeah.
like a couple of things listed in the guidelines as like criteria for being eligible.
Correct, correct. So, you know, things like kind of saying something along the lines, and you don't have to like list all of these to get the credit or whatever, but it's nice to kind of make sure we're on the same page of like, you know, her blood pressure is less than 185 over 110, she's not having a seizure, she doesn't have a hemorrhagic stroke, all that kind of stuff. Very helpful, you know, for the guidelines, et cetera. So, would need to kind of explain your thought process with TPA for this. Dosing was on point, so you give your bolus, which is 0.9 mg per kg, and you give, you give the whole dose, which is 0.9 mg per kg, and you give your bolus, which is 10% per minute, followed by the rest of it over an hour. Let's see. Then, let's see, you're monitoring, there's no signs and symptoms of the resolution of a stroke. So we look for like bleeding, hemorrhagic transformation, all that kind of stuff. What do you guys think about giving other agents that may increase bleeding right after giving TPA?
Are you supposed to initiate it within 2 weeks?
2 weeks for sure. This is a very interesting thing. I feel like as a resident, I was sent down this rabbit hole like a half a dozen times to look at this, and I was like, please stop. Generally speaking, after TPA, most people are really nervous about really starting anything, be it sub-Q heparin, aspirin, apixaban, all that stuff, for at least 24 hours. And it's just because everyone's so concerned about hemorrhagic transformation. So in this situation, you want to kind of say like, hey, please don't do this. All right, awesome. Thoughts, questions, concerns about giving TPA for ischemic stroke? Lovely. All right. Okay, tell me, we hit on antiplatelet therapy as a problem. So why are we going to give antiplatelet therapy?
It's not cardioembolic.
Yes, non-cardioembolic. What dose are we going to give?
2, 3, 25. There was a range in the guidelines.
There is a range in the guidelines. Just as like, I don't know, a life hack, always put 81. Like for sure, everyone is going to use 81. We are always going to use 81, regardless of what the guidelines say. Like no one uses 325 basically at all. Although it is an interesting fact that stroke in particular, it was 325 is most of the data that supports it. That's why the range exists. But this is like all those studies were done about 325 versus placebo. So it's like not shocking that aspirin helped, right? So no one's ever done the 81 versus 325 studies because it just seemed kind of silly. But we have all of this data that basically says that you get maximal platelet effect after, you know, or under 100 milligrams. So in that 80 range, that's why we do that. So although there's not a great study with aspirin 81 in stroke, it is just generally understood. And if you do 325, most people are going to be like, so always just please do 81. I can think of like no times that 325 would be right ever. So what are we going to monitor?
With the aspirin?
Yes.
Like signs and symptoms of bleeding.
Perfect. Thank you. All right.
Actually, I have a question.
Yeah.
How do we know whether or not someone is a candidate for dual antiplatelet therapy after they've had a stroke?
That is really a very interesting area of, to me, of controversy with regards to dual antiplatelet therapy. So what's the major study? CHANCE study, I think that came out in like 2015, and the CHANCE study did Plavix plus aspirin. They did dual for a period, and they discontinued the aspirin and kept the Plavix going. If you ever look at that, it will definitely help all of our counterparts of Asian descent, because it's like mostly Asian population that did that. And then another fun fact is that it was mostly done I believe it was in China, but there's maybe one other country. I have to go back and look at it. But the problem with that study in particular is that they have like, I forget how many were smokers, but it was like a ridiculous amount of people that were smokers. And so smoking has a ton of plaque buildup and stuff like that. And so the question is like, what do we do with that data? Is it for Asians? Is it for smokers? Is it Asian smokers? Like, what do we do with this? And so I am not really aware of many people that really do dual antiplatelet therapy, because although it does, as with anything, it decreases stroke, it increases bleeding, and I haven't seen anything that's really come out that's been compelling in kind of what to me would be the baseline population that you guys are going to see in the state of Georgia. So unless you can find me something different and teach me something new, I don't know if I've ever seen DAPT used in a stroke. It's more of just like a fun thing that we've tried out. Yeah, I'm trying to think of someone that I would do it. Maybe like, I don't know. I really don't think, I don't think I've ever seen it used. So, yeah, we definitely did not put that in here. To me, it's more of an esoteric conversation. Awesome. Okay, so you guys know the name of the study for why you do high intensity statins and stroke? It's a cute name.
Sparkle.
Yeah, Sparkle. Yeah. So you know, high intensity statins for this are, you know, a super big deal. So we're gonna do that. So dyslipidemia. To me, I don't really love that we call this problem dyslipidemia. Let's do, because it doesn't matter what the panel is. We're gonna give them a high intensity statin anyway. So the way that I would think about it, and I would counsel on a patient for this, is that the statin is not for your lipids. The statin is for your stroke. That's why we're giving it to them. It helps anti-inflammatory effects, helps remodeling in the brain, helps them build back happy neurons, plaque stabilization, all that kind of stuff. Now, if you have a magic pill that just reduces your lipids to a perfect panel, or taking a statin, you should pick the statin if you've had a stroke, and specifically a high intensity statin. So, what are our options for high intensity statins? Yeah, so Corva 40 to 80, Rasuva 20 to 40. That would be high intensity. I'm trying to think of anything else that would be interesting I want to say about statin therapy. How are we going to monitor it?
Left.
Yeah, especially a fasted lipid profile. But again, this was another rabbit hole I had to go down and see. Someone said, well, if you had someone that had a ischemic stroke, but they had like an LDL of 20, would you give them high intensity statin? And so that was an interesting drug information experience. I came to that. I would give them high intensity statin. So I think, to me, I don't know exactly what the point of fasting lipid profile would be, but nonetheless, people tend to do it. So that's that. Thoughts, questions, concerns? Stats. Feeling good. Okay. All right. I agree about the Tylenol situation. Did anyone do anything differently with the Tylenol? What did you recommend again, Sarah? I forgot.
We can see how often she's taking it, and
Yeah.
then probably stop her normal, give her a chance to get a little Tylenol for her osteoarthritis, and then go from there.
Did anyone else do anything differently? For that reasonable
I thought
factor?
it was continuing to, there's an interaction between the, or class T interaction between the alcohol and, which I don't know what she's taking it for, but yeah, you know.
Do something,
That's a lot of
yeah.
for a 67-year-old lady.
Yeah, with the stroke. I don't know how it is. Like, I think it's like a thing. Like when you become a 65-year-old woman, like just like it's like happy birthday, here's your Xanax. I don't understand like why that is, but I feel like everyone's got their Xanax, and it's like we really also need to change that. But nonetheless, it's pretty typical of what seems to be like the entire U.S. population. So yeah, doses too high. Doses greater than 4 grams are bad. Can cause toxicity. DC, officially you can get credit for DCing the Tylenol or DCing the hydrocodone Tylenol. I definitely agree. I would get rid of the hydrocodone. I don't think she needs that. Monitoring for signs of pain. What do you guys know about? I mean, I agree. Greater than 4 grams is really bad. What else? Is she old enough to meet any lower standards?
Her age?
Isn't it over 65 for 3? And then if you have any like LFT dysfunction or whatever, then you can actually go down to 2 grams. So that's kind of exciting. You know, one of the things, I think it is very important to look at how she's taking it and, you know, counseling point, stuff like that. So I agree this is totally right. When I was a 4th year, actually, I was on my institutional rotation. They made me do a 1-day NUE, so I had to like pull up 100 patients and look at them. And what I did was just calculate how many patients of them get more than 4 runs in a day if they got all their PRNs, and it was like 97%. It could do that, which was kind of shocking and a little scary. But then, yeah, counseling is good. All right. Tell me how you guys came to the alprazolam thing. So you guys like saw it on the MAR, and you said there is Xanax, and then what happened? What was the next thought in your mind?
Why should you do that?
Why should you? Perfect. But what is the indication? And then what would be your explanation besides simply that there's no indication? I agree that that is good, but like, what else could be?
Obviously, she's scared, but she just got a stroke.
So I mean, like, what else could be bad besides lacking an indication?
Like,
Fearless. Yeah. So always feel free to give that kind of stuff. So officially, it's no indication for the alprazolam is the problem, and then you got the problem, and then it's a problem in addition to just lacking an indication is that increased risk of falls on the Beers list. You keep the Norco, et cetera, et cetera. And then what are you going to do with it? Yeah. Did anyone do anything different than DC it? Yeah. So you got points here for DCing or tapering, but I do think that tapering probably would make sense. Although it's just like, it's like, oh, I just take it sometime because it's thunderstormy or whatever. So you can say, you can just be like, all right, I'm just gonna we're just gonna not do that. But you know, if they're taking it a lot, you would want to actively taper the medication. So, you know, to me, I think this is a very indicative case of kind of what you'll see. Chief complaint, shockingly, was a stroke. Shockingly, was the biggest medication-related problem. Hopefully, that's like almost always the case. So then go through all your stuff. You do your dosing there. Then, you know, here we kind of pushed you more towards like looking at a stroke and said, didn't it give you a prompt for secondary prevention?
Mm-hmm.
So you guys have that as a specific prompt. But again, when you come up with a brand new disease state, it's worth kind of thinking through the disease state of like what else you would add. And then you just look at the profile and kind of look for issues. So, you know, again, that's where the matching of the indication with medication. Let's say you just like forgot that or you panicked. You got it by doing drug-drug interaction check. You know, that's beautiful. So either way, you came to the same place, and I give you points for that. Any other things that struck you about this case? Awesome. I'll see if I can encourage them to come back in so we can watch this riveting video, and then we'll call it good.
So for the actual exam, if there's like something, will it be like explicitly stated like this that you guys want acute management and then like long-term, or like does it just depend?
For this, we did, I'm fairly certain we did not give any more explicit directions other than like find the issues.
Okay.
But for this, because we kind of wanted to like push you towards, so what we felt was kind of not fair with how we set this case up was that like, if you just look at it like on day one, you may not have decided to give them aspirin, because you wouldn't give aspirin
Right.
within 24 hours. So we thought if we give you just a little bit of a nudge, like what else would you do
Okay.
eventually? But in general, that was too much for this case. Keep it straightforward. So generally speaking, you can look at the patient kind of in that, whatever time period it is, you can look at it as like you're assessing them right now. Okay. All right, cool. You're good to go unless you need me. All right, let's watch this guy do this.
Taylor, she's a 67-year-old female who comes to the ED today with her daughter with a chief complaint of some slurred speech, numbness, and then loss of movement on her left side. She also has a noticeable facial droop on the left side. The daughter said the symptoms started about an hour ago. So the stroke team was called in for evaluation. The patient had a CT scan performed. Her blood pressure was elevated and it was treated with labetalol. On presentation, it was 200 over 112, and then after it was treated, it was down to 176 over 101. And she has a past medical history of hypertension, hyperlipidemia, and osteoarthritis. So the first problem here for Ms. Taylor is definitely her acute ischemic stroke. She's presenting with signs and symptoms of acute stroke. Their CT scan showed that there was an acute infarct, and it was negative for intracerebral hemorrhage. She presents within the time window since the symptoms started about an hour ago, so we're good there. The CT scan showed no signs of intracerebral hemorrhage. Her CBC was within normal limits, and there's no evidence of bleeding. And her blood pressure is less than the threshold of less than 185 over 110 for treatment. So we're going to recommend to give TPA at a dose of 0.9 mg per kg. And we give the first 10% as a bolus over 1 minute, and then the rest as an infusion over the next hour. So we're going to give a 10% bolus of 6.75 milligrams over a minute, and then the infusion is going to be 60.75 milligrams over the next hour. We need to keep in mind that we don't need to give any anticoagulants or any antiplatelets within the first 24 hours after TPA administration. And we want to make sure to monitor for resolution of the signs and symptoms of stroke, as well as any signs or symptoms of bleeding. So now that the acute stuff is taken care of, you're also asked to give some recommendations on post-discharge planning. So for secondary prevention of stroke, antiplatelet therapy is indicated for this patient. And so since she's had a stroke according to the 2014 AHA-ASA secondary stroke prevention guidelines, aspirin therapy is recommended, so we'll start aspirin 81 milligrams daily, and we'll monitor for any signs and symptoms of bleeding or dyspepsia. Next, for her dyslipidemia, so currently she's only on a moderate intensity statin, and now she's recommended for a high intensity statin based on her history of stroke. She's a secondary prevention patient according to the 2018 ACC AHA lipid guidelines. So I'd want to start atorvastatin 40 milligrams daily, and then have the patient monitor for any signs and symptoms of myopathy or myalgia, and we'll recheck a fasting lipid panel in the next 4 to 12 weeks. Next, when you look at our med list, the acetaminophen dose is too high, so she has both PRN acetaminophen and she has some hydrocodone acetaminophen on there. Doses greater than 4 grams of acetaminophen daily increases the risk of acetaminophen toxicity. And so as the orders are written, she can get well over 4 grams of acetaminophen in a 24-hour period. So I'd want to DC the PRN acetaminophen and then continue the hydrocodone acetaminophen and monitor for any signs and symptoms of pain so that we can escalate therapy if we need to. Lastly, she has alprazolam on her med list, and she doesn't have a documented indication for alprazolam. And so benzodiazepines actually can increase the risk of falls in elderly and on the Beers list. So first we'd ask the patient if she has a diagnosis of anxiety or something that would require benzodiazepine therapy. But if not, based on the dose, I would recommend to taper the alprazolam. So we could decrease it to 0.5 milligrams every 8 hours as needed, and then follow up with her to see how her taper is going.
All right. You guys have anything for me? Feel good? How's this gonna be? All right, awesome. All just quits.